Welcome. My name is Larissa Jacobson. I am the manager of Designee Marketing Services, and we are really excited to have you here. We're going to be going over our introductions first, and then our discussion with our experts, and then we will have a Q&A at the end and get to as many as we can. Just a little bit of background, Surgical Review Corporation, or more commonly known as SRC, was founded in 2003. We identified concerns with consistency of quality and safety surrounding bariatric weight loss surgery and determined that we needed to find a way to create a standard of high quality care. We began a journey to raise the bar on what healthcare excellence looks like and improve safety and outcomes for patients seeking bariatric surgeries worldwide. We have actually just celebrated our 20th year anniversary and have expanded to more than 30 surgical specialty programs. So our expert panelists today include Dr. Faris Abushamma from National University in Nablus, Palestine, as well as Dr. Jason Kim from Stony Brook Medicine in New York. And then from our SRC, we have Shelly Toon, who is our clinical quality inspector and kind of a jack of all trades, and has worked in multiple areas in the healthcare setting. So Dr. Abushamma, the first question I'm going to pose to you, what are some of the key challenges in continence care and how do they differ between men and women? When we had done our endometriosis webinar, we found that there were some pretty significant barriers to treatment, resulting in a 7 to 10 year on average delay from onset of symptoms. So what kind of things are you seeing?
Thank you, Larissa, for this. I think good questions to start the conversation about this. So I think the daily challenge that we do encounter as a urologist and a female urologist mainly dealing with incontinence in both males and women is first of all, and the concept of having incontinence or leaking urine all the time is just embarrassing for both males and females. And to be honest, I work in different places across the world, and I can tell that most of the patients, they first of all feeling shy to seek medical advice to ask about the problem of leaking urine, or they, for example, consider this as a part of normal aging process in either males and or females. I think also it's important to say that incontinence also sometimes linked to the sexual activities for both males and females, and most of the patients, they feel embarrassed even to share this problem with their partner or the part of their family members. And I would say, according to the most recent studies and recently one that we've done in our community in the Middle East, we do find that we had really, I would say, a reasonable large number of women complaining of incontinence, whether it's a stress urinary incontinence, which is leaking urine with some sort of movement, coughing, coughing, etc., or some sort of urgency incontinence, which is incontinence that is associated with inability to hold urine, or you have the feel to rush to the toilet, and sometimes you won't be able to reach to the toilet. Some of the problem of the incontinence problems related to sometimes to the lifestyle that you acquire. So sometimes it's simple just to report the problem, and then you can receive some sort of instructions just to get rid of these symptoms, such as avoiding drinking lots of coffee or tea, or participate in some sort of active exercise in order to reduce such symptoms. And also another type of pills or medication that we use sometimes also to help both males and females to decrease the severity of such incontinence. And I would say, to start with, so incontinence is really like an embarrassing big problem in the community that I do live in, and I think it's very important and essential that you need to report this to your physician, your GP, or your urologist in order to get at least advice or some medical treatment to help you to get rid of.
Thank you. Dr. Kim, what are some things that you're seeing in your practice? I know that you've
Well,
solely specialize in this?
yeah, I think one of the biggest challenges is finding the right specialist. Here what we find is among a lot of the general urologists, they're not aware of all the treatment options. I see the poll that about treatment options. Too often, the generalists, they offer just medications for like overactive bladder, and we find patients have cycled on them for 20, 30, 40 years with no improvement. And when it doesn't work, all they do is add another medication. Um, you know, People like myself, we're specially trained. We offer the latest therapies, including sacral neuromodulation, Botox, nerve implants. And it's clear, the studies have shown, at least in the US, the penetrance rate for these kind of therapies is only maybe about 5% of patients with overactive bladder. And it's clearly too small, considering about 40% of women may have issues with this. So I think it's all about finding the right specialist, because there's a lot of frustration from patients being sent to their urologist and they say there's nothing else that can be done, just take the medications, when clearly there are many other excellent treatment options.
Thank you. Oh, Shelly, you're muted. Sorry.
Some of the things that I hear, not even just as a clinician, but also in the community, especially being a woman, is the normalization of urinary incontinence. So many women, it's, if you're in a group of people and someone sneezes, oh, I got to run to the restroom. And it's become a normal part of society, but it's not normal. And there are things we can do to help. So what types of things with men? It's the opposite. It's a much more of an embarrassing. They don't want to seek treatment. What types of things do you guys do to help kind of mitigate that and get those patients coming in?
We do a lot of community outreach. We speak at seminars and things like this and make patients aware that, well, this is very common. They don't have to live with it. A lot of people think they just need to live with it. And so we talk about the treatment options that people didn't know about, whether it be for stress incontinence or overactive bladder, urgency incontinence. There's a lot of things that can be done. And honestly, what we're finding is once we treat some patients, they go back to their friends' social circles, and their friends are like, well, you're getting a sling for stress incontinence. Let me see how it goes. And then when they come back and report they're happy, all of a sudden they all want to come in. One of my best referral sources is a patient who's a hairdresser. I fixed her incontinence. Now she just sings the praises and tells everyone about it, and I get a lot of patients from her.
Mm.
Yeah,
I think I totally agree, and I think another point to add is the social media nowadays and internet really is just massively going through the social media. So we use social media a lot now to just raise the awareness that incontinence is not a normal process or an aging process. It's a problem, and you can address this problem whether you are a male or you are a female, woman or man. You can address this problem, and you can seek medical advice from an expert, as Dr. Kim Masson said. And I think you need to find the right surgeon or the right urologist in order to be offered the best treatment modality. As Dr. Kim said, sometimes pills may help. So medication for overactive bladder can help you to get rid of some of the symptoms. However, sometimes if your incontinence is really embarrassing or is related to what's called stress or weak pelvic floor muscle, you may get some sort of tapes or mesh or some sort of daycare surgery that you can obtain in order to get rid of this problem. And it's really a game changer. So the quality of life is completely different between somebody who's leaking urine all the time while traveling, sitting there in the coffee shop, etc., or someone who's got holding of his urine.
So kind of following some of that, because there is such sort of like a miscommunication, right, between what is normal and what is treatable. When patients are coming to you and they present to you, have they been dealing with these issues for a very long time? Is it something that's like, oh my gosh, this just started happening and I need to find somebody to help me? Like, what does that look like, and how does that impact that quality of life for them up to that point?
Well, as I mentioned, we get patients who've had these issues, for 40 years. It's crazy. And then, we do a minor in-office-based procedure and they say, I'm better. I can't believe I haven't done this sooner. I literally 10 minutes before I hopped on this call, I saw a post-op patient from a sling. She was relatively young, but she's like, I should have had this done 10 years ago. People think it's part of childbirth and this, and they don't realize what could be done. And for example, stress incontinence, leakage with coughing, laughing, sneezing, I could do an in-office procedure with no downtime, or I can go to the OR and put a sling in it, and it takes me about 10 minutes. And the change in their quality of life is just unbelievable. And so we see it all the time where the patients there's no treatment options till they come to specialists like us, and then all of a sudden it opens a whole new world for them.
Yeah, and it's very important also to highlight that the problem of incontinence or leaking urine is not, it's not per se that the woman, the patient or the woman, the man, that they are leaking urine. The problem is mainly that it does affect your mental health illness, does affect your sexual activity, does affect your relation with your partner, does affect your daily activity. So when you fix this, it's not that just you fix the problem of leaking urine from a patient, you fix the whole quality of life of patients, giving them the opportunity to get involved again with a partner, get involved again with a social meeting, get involved again with other physical activities such as gym or exercising, etc.
I love both of your passion towards the outcome for patients. It's really wonderful to hear, especially in this webinar. So thank you for that. But I did want to address when patients come in, how do you approach patients that are a little more fearful? You know, I'm getting surgery. Is this going to work? How do you guys address those type of concerns for patients?
So I may start with myself because I've done something which I think I help patients, especially women, to get familiar with the concept of having surgery for incontinence. So we have what's called a community group patients with incontinence. We've done more than 100 cases of incontinence surgery, and this group, some of them, they participate to be part of this community group. Patients suffer from incontinence and has surgery and get fixed. And most of the time I encounter new patients in my clinic, I usually, if the patient's got some fears or he's not trust in the surgery or the outcome of the surgery, I usually refer or relate the patient to that group where they do have a social media platform, WhatsApp group. They can receive advices from patients who had surgery before, listen to the experience, what to expect after surgery. And to be honest, I cannot remember when was the last time I offered a patient to have a treatment for incontinence, whether there's pills or surgery, and I found it difficult to convince them to be enrolled with this, because the problem itself is really affecting the whole quality of life of the patient. And usually when they come to my clinic, they've been suffering for a long time. So some of them, they've been suffering for years, and they come just to get this fixed and to get this done. So they are passionate, they are keen to get things fixed, and usually we can refer them to what's called a community group or incontinence community group to have further discussion and feedback from real patients.
Yeah, I think we do something similar. I mean, I'll take a step back. You know, not all patients go to procedural intervention right away. So we usually practice with a care pathway. So we introduce the concept of maybe behavioral modification, medications, and procedural intervention. But we introduce that concept very early on, so patients know if they don't respond early on to more conservative measures, that we kind of ratchet up the complexity. So we kind of put the idea of procedures in their head, maybe not now, but down the line. And the other thing is, I think we do something similar here in terms of reaching out to patients. We're lucky that we have very invested industry partners, and most of these devices we use, they have ambassador programs. And so what they do is they'll connect happy patients with the patients considering the procedure and let them know what the pluses, minuses, what they dealt with. And we find this very useful. And a lot of times my patients will volunteer to be part of these ambassador programs because they say, this is a game changer. It's changed my quality of life. And I can't, I want to tell everyone about it.
I think that, thank you for that, Dr. Kim. I think it really segues us into our next question, which is kind of getting into the diagnosis and care for these patients. So Larissa, did you want to go ahead and kind of take us into that next part?
Yeah, it really does. So because every patient is different and everything is individualized, how do you approach those assessments, especially, in cases of mixed urinary incontinence where it might be a little bit of both, we're not really sure the chicken or the egg here. Keeping in mind determining those risk factors, right, based on the individual's needs, the quality of life interference. And like you said, starting out with sort of that least invasive approach and seeing where we go from there. So how does that all kind of transpire for a patient?
For me, I involve a lot of shared decision making with the patients. You know, we'll do a thorough history, physical, and if they have mixed urinary incontinence, the first question is which bothers you more, right? And or what do you want to work on first? And I give the option. We can work on one of these, overactive bladder or stress incontinence. We can work on both, or we could see if one gets better. So it really depends, because a lot of times people say it's urgency dominant. And that's what really bothers me. I leak sometimes when I cough, laugh, sneeze, but I could live with that for now. Let's work on the bothersome part and then work on part two. Sometimes people say everything's bothersome. Let's just take care of it all. So I'm also willing to do that. So it's all shared decision making. So it's very important to engage the patient on what they want and their expectations. You know, if you make the decisions for them, oftentimes they're not happy. You know, I really want them to understand the treatments and be invested in the treatment plan.
Absolutely. I love collaborative care efforts. Yeah.
Yeah, I totally agree with you. I think what I do usually when I see patients with incontinence in the clinic, especially women with incontinence, the first thing I do is we have what's called a bladder diary. It's a diary that it's validated in many languages across the world. And I usually ask the patient before we decide how to go is to fill this diary over 3 days. And simply, you need to tell me how much and what type of fluid you do drink on daily basis, and how many times you go to the toilets during the daytime and during the night time, and how urgency you feel during the day, and what is the grade of your urgency. And I think it's really informative when the patient comes to the clinic with a bladder diary. And usually sometimes the patient, they discover, oh, we drink too much coffee, or we drink too much tea, or we have some sort of problem that we don't usually recognize before writing down what we do as part of our daily habits. And to be honest, I would say there is a considerable amount of patient that they don't really require medical or even surgical treatment. What they need is just to have some sort of lifestyle modification, hence, and some sort of weight loss and physical activity. And I would say 30%, I would say, just rough number of my patients with mainly prominent overactive symptoms, usually they respond very well to what's called a behavior treatment, lifestyle modification, and some sort of pelvic floor muscle exercise. So just to not give the idea that most or all patients will require surgery by the end. I think there's a considerable good amount of patients that may just get some good sort of help by just listening to them sort of advice from a urologist or a general physician.
When considering kind of those patient risk factors, are there ways that you mitigate that kind of strategically, as well as are there different concerns for men versus women? Well, Dr.
Yeah.
Kim, we'll start with you.
Sorry. Yeah, okay. Yeah, I mean, look, we have to assess the patient, you know, and like was mentioned, I often start with behavioral therapy and medications. If not, we consider procedural interventions. You know, medications, some of them are not benign. You know, for years, what we've seen here is people just always prescribe oxybutynin. Now, there was a JAMA study a few years ago that shows over age 55, there's an increased risk of cognitive decline, you know, and everyone's very keen to that. So now we have to counsel patients, and we actually use a different class of medications, more commonly the beta-3 agonists. So we counsel patients on that. But, you know, let's say that doesn't work, we move to procedural intervention, either be it stress incontinence or overactive bladder. I always am, in my back of my mind, I'm doing an assessment of, are they a candidate for the OR? Are they better served by an office procedure? Would they be able to catheterize themselves for Botox if you go into retention? And even things is, do they drive? You know, because we offer PTNS in the office, which is like acupuncture, but it requires a lot of visits. Here, you know, I'm in New York. Another consideration is, do they spend all year here, or do they winter in Florida? You know, because then we lose continuity of care, so we might offer a longer lasting treatment. And I tailor it based on these things. If they're not a surgical candidate, I steer them away from the things that need to be done in the OR and try to concentrate on office-based things. But it's also, again, shared decision making.
Yeah, I agree. I think to be honest, the incontinence patient, I think they are a special category of patient that you need to build really what's called a special relation between a physician and a patient. And to be honest, there is no right or wrong answer in treating patient with incontinence. So sometimes some patients may get benefit from some pills. Some patients requires to have a Botox injection to the bladder. Some patients requires to have some sort of installation therapy into the bladder. And I think the best way to deal with such cohort of patients, because they are really a sensitive, very sensitive group of patients, is try to have a good connection, good relation with them, try to understand what their concern are, what their problem are, because sometimes the concern may be related in a totally different way away from just leaking urine. Sometimes some of them they've been using pads for a long time that causing some sort of redness and infection in the area of the vagina, and they avoid them from having a proper sexual life and proper sexual intercourse, and they want this to be fixed and to be done, and that may affect their relation to the partner or to the family. Some of them, they've been withdrawn from the community. They don't usually participate in any social event because they have this fear that they may leak in front of people. So I think it's really an embarrassing problem. It has to be recognized that you should, as a physician, have a good relation with the patients in order to understand their concern. And as Dr. Kam said, and I think we have too many options for the patients. We have what's called behavior treatment. We have some medications, whether it's a beta-3 agonist or the new selective anticholinergic, even the office procedure, sort of Botox injection or TVT or TOT, all the valid options for both the overactive incontinent patient and the stress incontinence.
Something you guys have both touched on so far that we've kind of bounced around is that plan of care for patients, and something that SRC does require are care pathways for patients. How do you guys tailor those care plans? And in addition to that, how has that impacted your practice, having that plan of care kind of in place, even though each patient is different, having that kind of standard that you go to? How does that work for you guys, and how does that look?
Actually, we've published some papers on this. So, we implemented a care pathway for overactive bladder probably 7-8 years ago. When I critically took a look at some of the things I did, I felt like I was doing a good job of talking about overactive bladder and all the options, but I found that in 6 months, the follow-up rate was only 40%, and I'm like, why is this happening? I feel like I'm doing a good job, but then we really formalized it where we spoke about the options from day one and saying, if this doesn't work, don't lose hope, come back. We're going to move down from, least invasive, and we'll kind of ratchet up in complexity. We found some actually really nice improvements. When we talk about procedural intervention for overactive bladder, we call that third line therapy. First line being behavioral modification, second line became pharmacotherapy, and third line procedural intervention. And the penetrance rate traditionally for third line therapy for overactive bladder in the urology community was maybe 2-3% of all overactive bladder patients. And I thought, oh, I'm doing a great job. I'm doing a lot of these procedures. And what I found is, yeah, we were doing pretty good. We were at like 7 or 8%, but still that was too low. And we found that since introduction of the care pathway, our current third line therapy rate is like 20 to 25%, which is actually very, very high. There's been published data on this, and most practices that really concentrate this get between the 15 and 20%. So we see that our time to third line therapy was halved, from over a year to about 6 months, and patients were following up much more frequently. So I think it makes a huge difference, especially for patients to understand if this doesn't work, there's always more that we can do.
Do you have anything you'd like to add?
I'm thinking while Dr. Kim's saying about that, and I think all the time I see new patients with incontinence. The only thing I always tell my patient about is patient have to understand that this problem may need time to be sorted out, and there's always and like if one treatment does fail to improve your symptoms or to treat your incontinence, there's a second option and a third option, and most of the options in incontinence cares really, they are minimally invasive without really significant harm to the patients, and it's not, you cannot compare it even to the more complex urological procedures such as the oncology procedure. So I'm saying is the first, with my first encounter to the patients, the first thing I say, look, this most likely would be a long relation between me and you, in order to understand that it's not like an infection that you get the antibiotics and you go home with full recovery. That you need to have a good relation. You have to have a good follow-up, good visit to the clinic in order to get treated. And we start the letter step by step in order to achieve our goal, which is a dry patient by the end of the letter. And the most important thing that the patient should understand that if one step or one solution failed to improve your symptom, we have another one, and we have another one, and we have another one. And I would say, like up to my knowledge, like 95% of the cases of incontinence, whether this is an urgency incontinence or stress incontinence or mixed type of incontinence, currently we have really a minimally invasive solution if the behavior treatment or the medical treatment failed to improve the patient's symptoms.
Okay, so something else we look at for accreditation during the process, besides just those care pathways, is the additional team and consultative services it takes to kind of get there. And just like you guys have both stated, it can be a process and it can take some time to get us there. Yes, the 10-minute fixes are fantastic, and when they work, that's great. But there is a lot more that goes into that. Can you speak to us about the importance of those consultative services, such as physical therapy for, pelvic floor rehabilitation, and kind of collaborating that multidisciplinary team, such as gynecologists, urologists, and getting everybody together?
Yeah. I'll start with my experience. So I just to try to be comprehensive, the first encounter with the patient usually after reviewing the bladder diary and having a clear idea of what is the main cause of the patient incontinence, especially in the female section, especially when we're talking about women with incontinence. The first thing we do, we have a physiotherapist who is specialized in the pelvic floor muscle exercise, and usually we refer all patients to the physiotherapist in order to have a supervised session of pelvic floor muscle exercise. And also parallel to that, most of the patients, they have a visit to the gynae surgeons in order to make sure that we are not missing any problems such as pelvic organ prolapse, which is sometimes common if the patient is above the age of 50 with the previous multiple vaginal deliveries. After the patients sit with me, have the medication, have a supervised pelvic floor muscle exercise, have them visit to the to the gynecologist. Usually, the nurse, which is also specialized in the incontinence care, have like a weekly or twice weekly conversation with via phone or a face-to-face conversation in order to make sure that the patient is compliant with the medication and compliant with the physical exercise, and to assess regularly the response to the current treatment modality. And usually I see the patients every 6 weeks in order to make sure how much progress they do with their current treatment. And we don't rush to progress in our treatment modality from one stage to another stage quickly, because I think every type of treatment, whether it's behavior, physiotherapy, pelvic floor muscle exercise, should at least be at least experimental for 3 to 6 months in order to make sure the patient responds or not. And I will leave the surgical intervention as a last resort, and before I decide to go for surgical intervention for any patient, regardless to the type of the incontinence, I usually perform what's called an office procedure called a urodynamic procedure, which is simply it's a procedure that we fill the bladder with some sort of a fluid in order to make sure what is the capacity of the bladder and how much the bladder react as a normal behavior of the bladder, make sure what is the pressure inside the bladder, and what is the sensation of the bladder, and what is the abnormality. And the urodynamic test, as a complex invasive test, usually tell us exactly what is the underlying cause of the patient problem, and guide us what is the best treatment for this patient as a surgical treatment, what I mean. So as you can see, it's a long, lengthy process that the patient has to go through. And as I said at the beginning, and I keep repeating myself, it's essential for us as a physician or a specialized nurse to have some sort of constant, continuous relation with the incontinent patients in order to have a clear insight about the problem and about the progress of the treatment modality.
So where we're at, I'm very lucky because I have institutional support. We have a dedicated women's pelvic health and continence center. So we have 3 urologists who specialize in this, 3 urogynecologists who specialize in this. We have pelvic floor physical therapy. We have a colorectal surgeon. We have a urodynamics nurse. And on the other side of the building, we have general gynecology. So it's very nice because we're collaborative. I'm sorry, my phone just went off. And do you guys still hear me?
Yes, we can hear you. Okay.
All right, I lost the picture for a second. We're very collaborative in what we do. I'm sorry. Let me just pull this back up. It's interesting that you mentioned for you it's a long process. I think this may be some of the geographical differences. For us, I'm in the New York region, and people often come very frustrated with their symptoms, and they want to move on right away to whatever fixes them now. So we're probably a little more aggressive in advancing through therapies. Oftentimes patients come to me and they say, I want to skip medications. I want to go straight to a procedure. And, if we discuss the risk and benefits, if they want to do that, we have no problem proceeding in that fashion.
Yeah, it's really interesting. I think it does really, again, like you said, part of that collaborative care is a huge component, like onus on the patient. Like they should be involved in their treatment options. And we do live in the Freudian id generation, right? We want what we want it now. So I can totally understand that happening, with some patients wanting things like, no, we're fixing it immediate. When can I get in the door? And then others looking at it as more, the longer journey process, maybe. So with that, what are some current trends and innovations in continence care procedures, as far as maybe technological advancements and how that sort of changed techniques in the landscape there and improved patient outcomes for women specifically?
Yeah, I think we're very lucky because we're living in times where there's a lot of technological innovation, and I'm lucky to be involved with it. One of my niche areas is overactive bladder, and I love doing sacral neuromodulation, which is essentially a pacemaker of the bladder. I've been in practice for about 20 years, so I've seen the different iterations, and we're very lucky now that the devices are very advanced. Probably the newest innovation is implantable tibial nerve stimulators. So these are, for example, small implants. One of them is like the size of a nickel that you put in the ankle. It could be done in the office under sedation, and it stimulates the nerve. Now, there's 2 new FDA approved devices for this, and they last, somewhere between 3 years and 10 years probably. So this is a very new area. It's exploding. There's probably going to be about 4 or 5 different devices in the next 3 or 4 years, and I think it's great because it opens up different treatment options to the patient. In terms of stress urinary incontinence, for a long time, people were doing autologous fascial slings, and they were transitioning to mesh. There had been some concern with mesh use. I know, like in the UK, there are now a pause for using mesh slings. Mm-hmm. Where in the region where I am in New York, patients don't care. They want to say what works, and they just want it in right away. So it's a little different, but one of the recent innovations, well, actually, it's not recent. I mean, it's been around in Europe for over 10 years, but about 2-3 years ago, a new bulking agent was approved in the United States called that's a polyacrylamide gel, and that transformed how we do things. That's really taking off too. So I think it's nice because there's a lot of different innovations, and it's constantly evolving. And so I feel very lucky to be able to offer these therapies to my patients.
Yeah, I totally agree with you. I think we have lots of surgical, minimally invasive surgical, I would say, options, and some of them they are day case procedure. For overactive, we provide Botox, intravesical Botox injection for some sort of refractory overactive bladder to medical treatment. Actually, to be honest, as Dr. Kim said, we used to do lots of mesh procedure, and when I was in Bristol in the UK, we've done like this in routine basis. However, recently we received lots of feedback from patients, and I think regarding pain, chronic pelvic pain, and I still do this procedure, and I think it's really helpful for the patients, and I am less likely to encounter patients that really bother or complain from the side effects of the mesh procedure. And the bulking material is really good option for patients who does not want to have really major surgery. So yeah, we have lots of fancy, I would say, minimally invasive advanced technology to treat two types of incontinence, which are the overactive one and the stressed one.
Oh, kind of on that note, we did have a question from the audience. Are there any lifestyle changes or exercise that can help before I see the doctor? So, you know, before we even come through the door, what are some options that people have to improve their situation?
Yeah, I think this is a very good question before you encounter a physician to seek help. I think the general advice for all patients with incontinence, first of all, weight loss and weight reduction. I think obesity is there's a strong evidence that obesity is linked to both type of incontinence, whether this is overactive incontinence and stress incontinence. And I always advise my patients to try as much as they can to lose some weight and involve in regular physical activity or exercise, aerobic exercise. Also, lifestyle modification regarding fluid intake and fluid habits. I always advise patients with incontinence to decrease the intake of caffeinated drinks, fizzy drinks, teas and herbals, because they most of these drinks really irritate the bladder and give prominent symptoms of overactive bladder. Smoking also, there's a strong evidence now in the literature smoking affect incontinence in a bad way, and smokers usually they have a whether it's cough-related stress incontinence or bladder overactivity, it's not really clear, but I think also quitting smoking is helpful for a patient to reduce the symptoms of incontinence. And last thing I would add for female patients above the age of 45, 50, when they approach the menopause age, some of them, they really get good benefit from having vaginal estrogen cream, because with time the whole vaginal area will become atrophied and dry because of the lack of the hormone estrogen, which is really essential in incontinence in women. And some of them, if they use estrogen for like regular 6 weeks period twice weekly, and really get the area nourished again, and that help really in the continence. So most of these lifestyle modification, I would say, behavior treatment advice that really helpful for patient to try before even visit the GP or the urologist.
Yeah, I agree with everything that was said there. The one thing that I'm often fascinated by is caffeine. Oftentimes I ask patients how much caffeine they intake, and like, I don't drink any caffeine, I drink tea. I drink 5 green teas a day, and they often don't realize that green tea has more caffeine than coffee. So I think there's some education in that front. You know, I have people, maybe this is a phenomenon in the US, but, you know, they go to 7-Eleven and they have a double-handed big gulp container filled with iced tea, and they say, I drink 3 teas a day. Well, no wonder why you go to the bathroom every 20 minutes, you know. So there's some counseling on things like that.
Yes, well, I can't be one of your patients, because if you tell me to reduce my coffee, I'm out. I'm leaving.
It's shared decision making. Look, I'm drinking coffee the whole time. I tell my patients I enjoy my coffee, so I deal with it in the mornings, you know, as long as they understand.
It's a sacrifice I'm willing to make.
Yeah.
So we did just talk about some of those like things that people can sort of take initiative to make some of those behavior modifications, make some of those lifestyle changes. What are some post-procedure considerations that might be crucial when addressing urinary incontinence in women? So things that maybe need to happen kind of post-procedure.
Well, I think one of the points that was raised as excellent, you know, like if we do surgery for stress incontinence, particularly slings and things in postmenopausal women, vaginal estrogen, I think that's key. You know, there's a more people, and it's becoming very prevalent on social media, genital urinary syndrome of menopause. And you have to have healthy tissue quality there, and the appropriate vaginal flora can affect a lot of these symptoms. So, you know, that's one thing I use a lot of.
Okay.
Yeah. And yeah, I would like to add another point, which is I think is a valid point, which we published 2 articles recently about them. That pregnant female, which they are really young relatively to older female after menopause. Usually they complain really of overactive bladder symptoms and lower urinary tract symptoms. And pregnant females or pregnant women, especially toward the end of their pregnancy, they really struggle with going to the toilet frequently during the daytime and nighttime. And some of them, a significant amount of them, I would say, according to our study, 28% or so, a third of them, they really have incontinence during their pregnancy. And pregnancy as per se as a process is really demanding, requires lots of mental strength and physical strength. So imagine that somebody who's got this incontinence plus the pregnancy would really add a big challenge and trouble to them. So I would say it's important to counsel female patients during pregnancy if they complain of overactive bladder symptoms or incontinence, that this is a transient problem that usually resolve after pregnancy, because some sort of counseling and just informing them that it is something transient related to the pregnancy and going to be sorted after really help their mental health to just to understand that this is not something permanent related to the pregnancy. Because really I see lots of depressed pregnant females because of the overactive bladder symptoms, and what they need is just some sort of reassurance that this is just transient, as a pregnancy is transient, so incontinence is transient.
Our continence care for women accreditation has a focus point for patient education. And considering we've kind of touched on some of the things they can do, something as simple as green tea having caffeine, can you elaborate on the importance of that patient education before and after those procedures? How important is it to get these guys knowledgeable of their own diagnosis?
Oh, I think it's essential. We use a lot of handouts from our national societies, about conditions, and counseling them about them, what to expect for procedures pre and post procedure. I think it's essential. People need to understand fluid intake, fluid management, and oftentimes if you throw a lot of information in the office, it kind of goes in one ear and out the other ear. So we use a lot of handouts. We have them available all over our office, and we also point them to references on the different websites.
Do you think that education makes a difference preoperatively and postoperatively for patients?
Yeah, definitely. I totally agree. I think education and having the patients informed about what things has to be done before and after the surgery is really essential. And sometimes if the patient does not follow the advice or the instructions after the procedure, some of the procedure really fail. For example, in case of a TVT or mesh procedure for incontinence, stress urinary incontinence, if the patient gain more weight after the procedure and continue to smoke, for example, and they continue to have increasing intra-abdominal pressure, some of the patient, they fail the procedure itself. Plus the overactive bladder symptoms, sometimes even if you give medication or even if you give intravesical Botox for overactive bladder, and the patient insist on drinking large amount of caffeinated drinks involving smoking, does not decrease their weight. Most of the procedure, the patient they don't really respond well. So I would say in order to have a good outcome of whatever treatment that you receive for your incontinence, you need to have an insight about the problem and an insight about the factors that usually affect the problem in a bad way.
Absolutely.
I think patients also need to be educated on the procedures we're doing, for example. So a lot may have expectations that they're going to be completely dry afterwards, and it may be an unrealistic expectation. If someone's wearing 10 pads a day and I could get them down to 1 pad a day, I consider that a win. And they need to understand that before we go into procedures, because sometimes they will say, well, I'm not happy because I'm still wearing a pad, So you have to set the expectations, and that's part of the patient education before the procedure.
Yeah, really elaborating on those expectations. Yeah, where are we? Where are you now? And where can we get you? So I appreciate that for patients, because a lot of times they do have that concern afterwards of, well, was this really successful? And it kind of goes into mitigating those fears as well, kind of just nipping those in the butt right away. We're going to improve to a point where we can, and hopefully we get all the way there. But if we don't, we have to be realistic about that. So do you feel that being an SRC accredited provider, going through the process, just in general, getting those pathways and kind of looking at things from a different perspective than just your regular practice. Do you feel like that helps impact your practice overall, in any way, whether that's through marketing or education or pathways, kind of establishing and tying things together for you?
Well, for us, I think it helps with marketing. I mean, honestly, since we're in an academic center and this is our focus, we had a special emphasis on this. We were doing a lot of what was required already. Obviously, that's why we got the accreditation for a continence care center. But I think for marketing purposes, it's great because we're one of 6 continence care centers, I think, in the U.S., and we're the only one in the Northeast. And when patients understand that we have that focus, I think it makes them more comfortable coming here. They were already comfortable, but I think it attracts the patients and know they're coming to a high volume place that recognizes this as a kind of very important concern for a lot of women, and that hopefully we can help them.
As
Yeah, I
a,
would agree.
Go ahead,
Sorry.
Dr. Abushamma. Yep.
Yeah, I think I would give a clear example about how SRC help us here in the Middle East regarding the incontinence care. So since we've raised this webinar, I think a few weeks ago, and to just post it on social media or put it on the handout in the clinic, lots of patients, they are really interested to know more about incontinence, and they visit the clinic to ask about what available options to treat incontinence. So I think also having such conversation with expert like urologist, specialist care in incontinence or pelvic floor muscle exercise, etc., giving the patients the opportunity to listen about what options they do have as a treatment manager. So I think, yes, the SRC is part of raising awareness about the problem, and giving the patient to hear from the experts about what treatment options are available is really essential in providing good care for the patient.
Excellent. We SRC works really hard to help instill that confidence. We really want to partner with our physicians as we're doing today in this webinar. So I really thank you guys for being there and helping kind of do that. And on that note, being able to bring something to our audience, we did get a comment asking about stem cell. Do you guys have any knowledge to that at all, or any type of stem cell research that's being used towards continence care?
Yeah, from what I understand, there are different trials going on, and the results are mixed. Some
Okay,
show some promise and some show not. So I don't think it's ready for prime time yet. I don't think we know enough.
excellent. Thank you for that.
Yeah, I have no clue about what stem cells has to do with the incontinence, but yeah.
That'll be the evolution of the landscape later on down the road, right?
There's definitely studies ongoing right now. Some people are taking stem cells and trying to inject it near the sphincter and things like that. But
Okay.
the data is not robust enough yet to recommend it.
Perfect. Thank you.
We do have another question here, and we are right at the end. What things should a patient consider when looking for a continence care provider? Like you said, they can, for lack of better terms, sort of waste years going through a general practitioner. So what should they consider when trying to find somebody who specializes like you do specifically in these areas?
I think it's vitally important to make sure that they offer all therapies. Some people only offer a fraction of the therapies, so the patients they're not getting exposed to everything. It may lead to frustration because they may be undertreated. Sometimes from a patient point of view, it's very difficult. I would look at the physician training to make sure they have the appropriate training in this field. Here in the States, a lot of us have specialty fellowships in urogynecology or female pelvic medicine and reconstructive surgery. I would ask around, and a lot of times social media can tell you that. At least another thing that I find here in the States helpful is in local communities, a lot of the Facebook mom groups. They always have the right recommendations, and they know who the people to go to are. Leverage your social media contacts. I think these are all helpful, and plus, like SRC accreditation and things like that. You're going to a place that does a lot of this. Unfortunately, in the U.S., I think there's only 6 of these continence care centers in the whole country.
What does that look like in your area, Dr. Abushamma? He's saying there's only 6 in the US. what does that look like in your area as far as specialists like yourself?
So I think I totally agree with him. I think unfortunately a woman care or female urologist or whatever you want to call it is really, I would say it's a specialty with few centers in the whole region. I would say you would be able to find a urologist to treat your kidney stone frequently, and you would be able to see a urologist to treat your kidney cancer rapidly. But regarding continence care, because it's a complex issue and it's really it's an issue which you usually get, like there's an integration between a urologist, gynecologist, physiotherapist, and some sort of other specialties. So you can tell that, for example, in UK, when I did spend good time there, they at least 4 or 5 main centers, they do the incontinence, one in the southwest and another one in the north, and then the other one in London and around London. In the Arab countries in general, there are 4 to 5 like functional urology centers across the whole area. They really specialized in continence care and female urology, and really it's an innate specialty where you need to have, as Dr. Kemp said, a comprehensive. It's not only urologist, you need to have a comprehensive service, which is some sort of collaboration, integration between a urologist who is specialized in female and functional urology, a gynecologist, and also physiotherapist, a care specialist nurse that she can spend good, or he can spend good time with the patients regarding counseling and talking about the procedure and having a good preoperative and postoperative counseling. So I would say it's a unique specialty. You need to find what is the reputation of the center. Look for the SRC accreditation. Look for the outcome of the surgery that the surgery, for example, done, in order to make sure that you get the most appropriate treatment by the most appropriate hands.
Yeah, absolutely. Absolutely. Just for everyone on this call, whether it be for continence care issues or something else, we do have a Find a Provider tool on our website so that you can look for a specialist that has been accredited by SRC and gone through that. We are coming up here on time. I want to thank both Dr. Kim and Dr. Abushamma for joining us and sharing your expertise and really shedding light on this issue, like you said, with it being something that can be very personal, can be very embarrassing. The more we talk about it, the more we normalize treatment versus normalize dealing with it, right? So I love that. Again, Shelly, thank you so much for all of your clinical expertise with us as well. Again, we will be sending out this recording. We will be including bio information and links to the provider website so that if you want to reach out and get in touch with any of providers and our experts here today, as well as if you have any questions or whether it be about the continence care webinar, about continence care in general, or more about SRC accreditation, please go ahead and email the designee services at surgicalreview.org. And we will be happy to connect you. I want to thank everyone in the audience for joining. The more we come together on these issues and these topics, the more we normalize it and the healthier we get to be collectively across the globe. So thank you all for your time today, and we look forward to seeing you in future webinars.